Dr. Jim Christina is the CEO and Executive Director of the APMA, and he's going to talk to us about registry reporting.
So Jeff mentioned that APMA has developed a registry, and he mentioned there's different types of registries. So basically there's two types of registries. There's what's called qualified registries, and then there's qualified clinical data registries, or QCDRs. The qualified registries only report MIPS measures, and each registry goes through a process where they apply to CMS and they get designated as a qualified registry. They don't have to report on all MIPS measures. They may choose to report all MIPS measures, or they may just choose to report certain MIPS measures. If it's a qualified registry and say it's associated with ophthalmology, they may only report MIPS measures that they think are appropriate for ophthalmologists. A qualified clinical data registry, which is what the APMA registry is, can report on both MIPS measures and non-MIPS measures, or what they call QCDR measures. And those can be measures that have been developed to get more data on particular things. For example, in the APMA Qualified Clinical Data Registry, we have a comprehensive diabetic foot exam. That's a non-MIPS measure. You won't find that measure in the list of MIPS measures, but we think it's an important measure to start to collect data on, because the process of becoming a measure that's included in the MIPS program means you have to go through a process where you actually go to something called the National Quality Form. You get the measure endorsed by NQF, and typically then when you submit it to CMS, they will accept it as a MIPS measure, so it could become part of those MIPS measures. The downside of QCDR or non-MIPS measures are if they can't benchmark that measure. So one of the things that gets a little bit into the technicalities of these measures, when you're trying to do a measure, so you've picked your 6 measures and the maximum points you can get on that measure is 10, that's based on your performance on that measure. And for some measures, if they're very high performing measures, you need to get a benchmark score of like 90 or almost 100% to get those full 10 points. If they can't come up with that benchmark, and they can't on QCDR measures that don't have enough data on them, then they will only give you 3 points for that measure. The same as if you just did one measure on one patient. You get those 3 points. So it's important, like if you look at the APMA registry, you could choose to report data on the comprehensive diabetic foot exam, but I wouldn't include that in the measures. You can report data to a registry on more than 6 measures, but you want to choose your 6 best to actually report to CMS. So all a registry is it collects data. And the APMA registry, the way we've built the registry, is one piece of it is to collect data to allow you to submit your data to CMS for MIPS. And as we went over, for 2018, there's 4 components to MIPS. The cost component, you don't have to do anything. Somehow they're going to calculate that for you. As Jeff said, we're not sure how they're going to do it, but they're going to do it somehow. You're going to get a cost score, and your cost score will give you 0 to 10 MIPS points. It's worth 10%. The other 3 components, you have as you went over, you have the improvement activities, you have the ACI. Those are attestations. The APMA registry will allow any member to submit through the registry to go in and do your attestation, and then the registry will submit that data to CMS for you. That doesn't cost you anything. It's a member benefit, so you can go in, you sign up for the registry, you then, once you're all signed up and everything, you'll log into the registry page, you'll see your dashboard page, you'll see a spot to attest. You can go in and attest to ACI and improvement activities. Yeah, question?
So you can do your attestations through the APMA registry, yet for the other scores still submitted on claims. Is that correct?
Correct. So the question is about the quality component. If you do 2 components through the registry, could you still do the other component through claims? Absolutely. You could do it through claims. You could do it through a different registry. You could also do it direct to CMS if your EHR is set up to download the file that will allow you to submit your quality data directly to CMS. APMA has also been working with the various vendors to try to get them to integrate with the APMA registry. And what that means is if they integrate with the registry, you'll have the ability to directly send that third component, the quality component, to the registry seamlessly from your EHR to the registry. So the other thing is that in the APMA registry, this year for 2017, we had 11 measures in there. We've expanded it for 2018. So we have 18 different measures that you can report on through the APMA registry. We think these 18 are probably the most common ones that a podiatrist would use. So there's 18 that you can use. If one of your measures is not on this list, and you're going to use the APMA registry, you're not going to be able to report that measure to the APMA registry. You'd have to find another mechanism to report those quality measures. But as you can see, these are pretty common ones that everybody should be able to perform and are applicable to podiatry. And these are the non-MIPS measures that we have in the APMA registry. So you see the first one is the diabetic foot and ankle care, the comprehensive diabetic foot exam. That's a non-measure. We'd love to get the data on that measure. We don't recommend that you use it to report to MIPS, but we want to collect this data because the other component of the registry is to collect data and use that data. As Jeff said, one of the things that's going to be coming up are these alternative payment models. So some of these alternative payment models may eventually come to fruition to be almost a diagnosis-related group like a hospital does, so that you would get one payment, say for a heel pain patient. And so patient comes in, they have a diagnosis of plantar fasciitis, and you're going to get one payment for the course of treatment of that patient. How are they going to come up with the reimbursement amount for that? They're going to have to use data, and we're going to have data argue with them to say the typical heel pain patient should include reimbursement for at least 5 office visits, 2 injections, 3 strappings, physical therapy, orthotics, whatever. But we need to get that data so we can show them that this is an episode of care for heel pain that typically happens. And that's how we'll start to use all of the data that we get. We also want to show that we do certain things. So if we go back to this list here, when you talk about falls prevention. So falls prevention is a big entree into these alternative payment models, these value-based payment systems, because it costs insurers a lot of money. So if you're doing the falls measure and we collect that in the registry, we can say, look, we have data in our registry. 2,000 of our members did the falls prevention measures. And so that gives us an entree into these other payment models. The other 2 that we've gotten are from another company that allowed us to use these. One has to do with ankle orthosis for ambulation and functional improvement, and the other has to do with functional outcome with foot orthotics. So those are just 2 other ones. Again, they're probably not, unless we have a lot of people that put in a lot of data on these, they're not going to get benchmarked. If they don't get benchmarked, you're not going to be able to get your highest performance score. The other thing that we did, if you noticed in 2017, there were what they called these measure sets for different specialties. Well, there wasn't one for podiatry in 2017. So we petitioned CMS and we came up with a list of 6 measures that we thought were applicable to podiatry. 2 of the measures are our measures that we developed, 126 and 127, that has to do with the neurological exam of a patient with diabetes and evaluation of footwear. Very easy measures, easy to do on your patients with diabetes. Then we put in the BMI because we made the point that obviously if you have a high BMI, you have a higher risk for diabetes, so it's related to something that we deal with. The falls risk assessment, obviously patients that have diabetes and loss of protective sensation are at greater risk for falls. We think that's a very important measure. That's also a high performance measure. And then the final one we put in was the tobacco care and screening. If you do a measure set, that's it. We have 6 in our measure set. You do those 6 measures in the podiatry measure set, I would recommend doing those. All of those in there are, you do them once per reporting period. So once you've seen the patient and you've done it, then you're done with it. There's a couple caveats with this. One of the things that Dr. Lehrman talked about was, yes, you might have a patient that comes in for a 11721 and the measure has an E&M associated with it, so you don't have to worry about that patient. You don't have to worry about that patient for that visit. They could come in later in the year and maybe they came in because they've got tinea pedis, or they come in because they have heel pain, and suddenly that patient that you normally are seeing for their covered diabetic foot care is now getting an E&M service. They now become an eligible patient for all the codes that are related to E&Ms. The other thing is the first two measures, 126 and 127, because we developed them, if you look at the denominators of the specifications of those measures, it includes our typical foot care procedures that we do, 11720, 11721, 11056. So you could have a patient that's a non-E&M patient, and you'd have to just report those two measures on that particular visit. Does everybody understand that? It's a little bit, the eligibility depends, it's per visit. It's not an eligible patient or not an eligible patient for a particular year. Improvement activities. So Jeff talked about doing some improvement activities. I think the fall screening is a good one to do. Again, we're trying to collect data on doing this. So you do the fall screening and you do the appropriate things. That's a medium weight. That gets you halfway there to what you have to do. You pair that with your prescription drug monitoring, and you'll be right where you need to be in terms of getting your full 15 points for improvement activities, which, as he said, you'll get an additional 5 because you did one of the things. So you really end up with a score of 20. One of the other things he didn't talk about, because it gets a little bit complicated, but another way you could avoid the penalty is doing claims. Last year it was just one claim. You do one measure on one patient through the claim system. Well, technically, if you do 6 measures on one patient, you're going to get 3 points for each of those measures. 6 times 3 is 18. 18 out of 60 is 3/10, 0.3. 0.3 times 50 is 15. So you will get there with the math. If you do, you could pick 6 measures that you can do by claims. You could have one eligible E&M visit on one patient. You could document those 6 measures, and you also will avoid the penalty. It's just an alternative way to do it. It gets a little more complicated because you got to make sure you got an eligible E&M. It's a Medicare Part B patient because you're doing it per claims. And then you have to make sure you document all 6 measures and the patient is eligible for those 6 measures. But it can be done that way, and that would get you to, again, score 15, you participated in one of the things, you'll get a 20. You might want to do both. So if you do the improvement activities, which is pretty easy to do, particularly if you have to register for prescription drug monitoring, you get 20 for that one. You do the other one, you get another 15. Now you got a MIPS score of 35. You didn't have to do that much work, and you may get some bonus points for that. So this is how you do the APMA registry. So you basically go to the sign-up portal, go to apma.org/registry, and you'll get to the sign-up portal. You'll sign up. There's some information that you have to fill out about your practice. You'll then click. There's also a business associate data use agreement that you click on. Once you do all that, you'll be signed up to the registry. You'll get an email. It'll tell you how to go into the registry itself, set up a password, and do all those things. Once you get in there, then you're going to be able to go ahead and do your attestation, or over the course of the year, you'll be able to track the measures that are being reported and those types of things. It is open now. If you signed up for 2018, you should have been going through the sign-up process. So if you haven't done that and you signed up for 2017, or if you haven't gotten the information on that, get in touch with us and we'll help you work through the process. Dr. Towers put together an exhaustive instruction manual that tells you how to do everything. Yes, sir?
For 2017, are there any attestations that need to be done, or is there a deadline for that?
Yes, the question is for 2017, Are there attestations that need to be done? Yes, if you did improvement activities or advancing care information, you need to attest. You can attest directly with CMS. You have to have your EIDM number and you have to be able to navigate through that. Or if you signed up through the registry, you can attest directly through the registry. The deadline technically is March 31st. If you're using our registry, we're requiring a deadline of March 24th so we can calculate all the data and then get the transmission to CMS by the 31st of March. But there are deadlines. It's typically, so for 2018, typically the reporting period for reporting all this information is the first 3 months of the following year. No advantage to reporting it earlier on in the first 3 months because they're not going to be able to calculate anything until you get to that point. The other thing to realize is if you did claim submission, so say you were just trying to avoid the penalty, you can go in right now and check to see what your MIPS score was based on claims. They have a website on the CMS website. Again, you have to have your EIDM number. If you don't have one of those, it'll give you instructions on how to do it. You can go in. I did have a doctor that contacted me about it. I walked him through going through the system. He went on and lo and behold, because he said, I just want to be sure, I only did a couple patients with smoking. I want to make sure I'm not getting penalized next year. He looked, he had a MIPS score of 3, so he's not going to get penalized. Yeah.
Forgive me if Jeff already covered this, but if you submitted any quality measures via claims, the last date for 2017, the last day to do so is by March 1st, 2018. So if you haven't done it yet and you want to avoid the penalty.
Right. So the point that Gail is making that if to submit your claims, if you're going to do quality by claims, March 1st is the deadline. What I was referring to is if you're going to do registry type reporting, those types of things, March 31st. But claims, and technically, you're probably not supposed to hold claims more than 6 months, is that correct? So this would be claims that you did in the last 3 months of the quarter or whatever. You get those in by March 1st. So the other thing that we're going to do is if you didn't sign up for the APMA registry, we're going to open that up for reporting, for signing up again, probably March 3rd. So probably in another week or so, that will be open again. You can go in and sign up so that you're signed up for the registry for 2018 if you haven't signed up for it before. Most registries, you'll pay a fee to utilize. That fee can vary anywhere from $300 to $600. To use the APMA registry, we're not charging members a fee. It's a member benefit. However, unless your EHR vendor is integrated, you're not going to be able to do your quality components.
So again, let me question, if I sign up now for the registry, I can still report 2017?
No. The question is, if I sign up now for the registry, can I report 2017? No, you needed to have signed up in the sign-up period that we had previously. This would be signing up to use the registry this year to report next year.
So I can still go through CMS and report for 2017?
Yes, sir. The question was, can I still go to CMS? Yes, you can. You can go through the CMS website. Do you have a question?
I did. You said if there were certain EMR companies that were ready for download. Do you have that available already?
The only one that's integrated so far is MediTouch. They're the only ones. We've reached out to and had conversations with, Diane's putting up, how many? 35 different EHR vendors that we have reached out to, worked with them, set them up to talk with the company that's built our registry that has to work with them to do the interface. So we've had a lot of conversations. We're trying to move that forward. It's really just, they have to do some work internally. They have to do a lot less work if they're 2015 certified, but if they're not 2015 certified, they may have some internal challenges to do the work, and they either don't want to take the time or the cost to do it. We don't charge them to integrate. This is all the cost to them in terms of production and software engineers and that type of thing. Oh, Monday, March 5th. I said the 3rd. It's the 5th we'll reopen the registry. And again, there's the website that you can go to. One of the other things I'm pleased to announce is that we have entered in to an agreement with a vendor for an analytic app. at a severely discounted price for APMA members. So this analytic app is called My MIPS Score. The normal price for this app is $4.99 per year per doctor, and the price that APMA members will be able to get it for is $349. What this analytic app does is, a lot of times if you're in a group and you're wondering, hey, should I report as a group? Should I report as an individual? This is an incredible app in that it looks at all the measures that you're reporting on. It will tell you how you're performing on that measure. It will tell you if there's other doctors in your practice, if they're all in there. It will tell you whether there's an advantage to report as an individual or as a group. It will also, say you're doing a measure and you look at your performance, and say your performance is 50% on that measure. Well, in some cases, if you improve your performance to, say, 75%, it's going to make a huge difference in your score on that measure. Because remember, I talked about the benchmarking on it. On other times, you could go from 50% to 85%, and it might not make a difference. This app will let you look to see, if I change my score performance from 50 to 80, what happens to my MIPS score overall, and it also calculates, based on Medicare data, and the best Medicare data it can get, what your incentive payment is going to be. If you're trying to maximize your MIPS incentive payment, if you're going to go full bore and do everything you can with MIPS, this app will easily get you much more than you invest in the app. An additional benefit, and this is the kind of just a byproduct of this app will also collect all your quality data and be able to transmit it to the APMA registry. So if your vendor has not integrated, for $349, you can get a great analytic app, and an additional bonus is, this is a workaround on how you could get all three of your components into the APMA registry, because you'll still be able to attest for the improvement activities and the ACI, but this also allows you to do your quality data as well, and will easily pay for whatever you would have to invest in. The analytics is the reason to purchase the app. You don't have to get it. If you still want to just report the ones that you can report, the CPI and the improvement activities, you can do this. But this is a really good workaround that we found, and it's really a great analytic tool. It's called My MIPS Score. We're hoping to have it available for purchase within the first couple weeks of March so that you can start to use it. You can go to their website and see a demo on it. We're going to do some webinars so you can really get a feel for how it works. But it's a really good analytic tool, and it's a good workaround to now get all your quality data into the APMA registry. And that's all I have about registries. Be happy to answer questions.
If you've already reported for 2017, when and how will they inform you of what your incentive?
Say that again?
If you've already reported for 2017, when and how will they let you know what your incentive?
They're never real firm with dates or things, but I would imagine it would probably be in the fall of this year. If you're going to get a penalty for 2018, unless, do you know when they're going to?
No,
Oh.
nobody knows.
Yeah, nobody knows. So probably in the fall of this year. But if you're going to get a penalty, you'll get a letter. Obviously, those that are getting penalized for 2019 will get a letter based on what they did in 2017. Any other questions? Any questions in general about MIPS, about the registry?
You just do all that work and wait 2 years.
Yes, you do all the work and wait 2 years. That's correct. That's the bottom line. And somebody asked earlier, before the meeting started, is this just going to stay the same, or are we going to stay with MIPS? Probably not. It will probably change in a couple of years. That's just, they continue to look for something, and they haven't found it yet. Yes, sir?
What are they looking for?
They don't have enough money to pay for all the services that are provided, so they're trying to figure out a way to reduce the payments and cover everything. That's the bottom line. I mean, the pie's only so big, and so they come up with all these ideas based on payment for quality, payment for value of services provided. But truly they're not interested in that, because we've gone to them and we've made proposals about things like a comprehensive diabetic foot exam. So we've said to them, why don't we do a pilot program? If you allowed because right now every patient with diabetes doesn't necessarily qualify to even be seen for an exam. I mean, as a new patient to you, they could, but beyond that, there aren't. And you got to jump through all these crazy hoops with class findings and things. So we said, well, what if every patient got a yearly visit that was covered, and then they got risk stratified? The risk stratification has already been set up by the American Diabetes Association working group. So you can look and see what's 0 risk, 1, 2, 3, high risk, and then you base your care based on their level of risk. If it's a 0 risk patient, you see them once a year. If it's a low risk patient, maybe you see them twice a year. High risk patients, they might be seen every 4 to 6 weeks. So you get away from this idea of having to fill out all these silly class findings, which obviously we know a certain percentage of patients don't have a dorsalis pedis pulse, but that's a class finding for a patient with diabetes. Doesn't make any sense. They're not at higher risk just because they have an anatomical variant, but this would actually make sense, and you'd be able to, you wouldn't have to worry about it. You'd know you get paid for providing that care on a regular basis. They won't do that, and that would save them tons of money in the system, because you'd prevent complications, you'd prevent ulcerations, you'd prevent hospitalizations, and ultimately amputations. And those are the types of things that we continue to propose to make care better and really have value to the care. Like Dr. Lehrman said, there's no evidence so far that we did PQRS, we did meaningful use. Where's the evidence that that improved care? If it didn't improve care, they'd still be doing it, and you'd be getting paid to do it, but it doesn't. So they're just searching to find a way to provide value and quality of care, but they haven't found it. Yes, sir.
Yeah, you might want to edit this question out, but I'd like to know, can you find out how much in their budget was spent in the store they bought the product in Colorado when they were formulating this whole?
Which?
Let's talk about what did the payroll
What were they
cost?
smoking, I want to know.
What did the payroll cost to create all that, is what he's saying?
Well, that, and where they got the product, at what store in Colorado, what they were smoking.
Yeah. Yeah, there's a lot of things that they did. I mean, if you think back to when they implemented electronic health records and what they wanted to do, remember the original proposal of electronic health records was everybody was going to be able to communicate with each other, so the patient would walk into your office and you'd be able to pull up their record. Oh yeah, you just saw your doctor for your management of your diabetes, your A1C was this, I see your most recent blood work, all of that. Didn't work. Why didn't it work? They found out that they let all these different EHR vendors pop up and none of them talk to each other. Why didn't they just develop one EHR and make it available to every Medicare provider? And that would have been a lot less than what they paid for meaningful use payments to providers, and providers would have been a lot happier. A lot more people would have engaged in using an EHR because you wouldn't have had any cost to you to do it. They would have provided the software for you.
They could have even charged for it and never done it.
Or they could have charged for it. So,
It would have been easier, and they'd have rather done that and pay them than it would be going through what they were.
yeah, so they've obviously missed the mark on a lot of things. Hopefully, some of this will improve. We continue to make suggestions to them. A lot of times they don't listen.
Are these doctors, who are telling doctors how to perform? Are these doctors?
No, they're not doctors. How much time? Real quick anecdote. So, we're active in advocating. So when the 2016 presidential elections were up, we had some events. We weren't at the convention per se, but there were events that surround the convention. So I went out to Cleveland for one of the meetings, and they had the whole panel up there, and since we were one of the co-sponsors of it, we got to ask like one of the first questions. And that's one of the questions I asked. I said, why don't you involve the clinicians that are actually providing care when you start to make these changes in healthcare? And what I got was 5 people sitting there with a blank stare on their face. And finally, somebody stumbled out some answer that didn't make any sense. So it's like it doesn't even occur to them that the doctors, the clinicians, should be involved in this healthcare reform that they do. And that's really what you're dealing with. But no, there aren't Typically, there aren't. They bring in economists, healthcare experts, and that type of thing to these.
So basically no one that knows anything.
Correct.